Hello, everyone, and thank you so much for joining us today for our second series in our newly launched ALS Research Publication Review Initiative. Our inaugural series, which was launched during Q2 of this year, focused on genetic testing and counseling in ALS. And the review of both of those publications in that series was tremendously helpful to the ALS community. Our topic for Q3 is under the umbrella of biomarkers in ALS. And my name is Jen DiMartino, and I'm the Executive Director of ALS One, an organization that was founded in 2015 to advance critical research towards treatments leading to a cure for ALS, while simultaneously providing essential equipment, care resources, and really an incredible community of strength to individuals living with ALS and their families. We are extremely proud to be partnering with NEALS on this initiative, which is aimed to bridge the gap between the authors of important ALS research publications and the ALS community. This initiative was the brainchild of the NEALS NICE Committee, which is an acronym aptly named for the NEALS Information and Community Education Committee. They saw a gap that existed in connecting the ALS community to the authors of important ALS research publications, and we're extremely proud to be partnering with them on it to amplify the work that's being done in the field of ALS, while enabling the ALS community to ask questions to gain a better understanding, not only for them, but for the entire ALS community at large. So we welcome you, and today we will delve into the publication entitled Longitudinal Biomarkers in ALS, which was written by a number of people, including Drs. Fen Huang, Yuda Zhu, Jennifer Hsiao-Nakamoto, Xinyan Tang, Jason Dugas, Miriam Moscovitch-Lopatin, Jonathan Glass, Robert Brown, Shafeeq Ladha, David Lacomis, Jeffrey Harris, Kimberly Scearce-Levie, Carole Ho, Robert Bowser, and James Barry. And we are truly honored to have two of those authors, Dr. Bowser and Dr. Barry, here with us today, along with another fantastic lineup, including Dr. Stephen Johnson from the Mayo Clinic. He is a NEALS NICE community member. Lori Larson Heller. She is a NEALS Research Ambassador, as well as a NEALS Patient Advisory Committee member. And Jean Swidler, who is the founder and executive director of End the Legacy. And she is also a research ambassador. So we'll hear from each of them today. But first, it's my honor to introduce James Barry, who is a Winthrop Family Scholar in ALS Sciences, the director of the MGH Multidisciplinary ALS Clinic, and chair of the Division of ALS and Motor Neuron Diseases at MGH. Dr. Barry is also the co-chair of NEALS. So welcome, Dr. Barry. We also have Dr. Robert Bowser, who is the Chief Scientific Officer, the John P. and Betty Van Denberg Chair for Neuromuscular Diseases, and Professor and Chair of the Department of Translational Neuroscience at Barrow Neurological Institute. Dr. Bowser is also a member of the NEALS Scientific Advisory Board. Dr. Barry and Dr. Bowser, it's our honor to have you with us today. And it would be wonderful if you'd both give a brief synopsis of what drove you to help write this important article, and a little bit about biomarkers, maybe just for the lay community, what in simple terms, what a biomarker is, and just your background and connection. So either one of you can start.
Silence. James, you want to go first?
Sure, I'll go first. So yeah, first of all, thank you for having us. We're really excited about these initiatives and about, really trying to get some information about some of the key things that are going on in the field, because there's so much changing for the better and so many positive kind of breakthroughs that are happening that, that don't always make the popular press. This paper really kind of was a culmination of work that Bob Bowser and I did with a group of investigators, all of whom are authors on this paper, over a number of years, which was to launch a biomarker study that collected blood and spinal fluid from people with ALS at intervals of every 4 months over, across a number of years. And there were about 125 brave souls who joined that study and really did it incredibly selflessly, and provided kind of samples and clinical data that we would then use for years. In fact, we still have samples in the NEALS biorepository that are still leading to breakthroughs in ALS science. So, but this was one of the projects that we really had envisioned from the outset of that study. So it was incredibly exciting to get to work on it and sort of see it come together this way.
Yeah, I can just add to that. So I think, Jen, you mentioned what's a biomarker. Really, a biomarker is almost anything you can measure reliably, quantitatively, and relate that to maybe a clinical feature or condition. So, there's a large host of types of biomarkers. So, doing, your blood pressure when you go to your primary care physician all the time, that's a biomarker. Looking for our heart ailments or other things. So, doing a lipid analysis, another biomarker. So biomarkers are really anything you can measure and follow in individuals. So we have, as James mentioned, started this study now many years ago. James was a lot younger then, if I recall. And, we really set out as we were trying to discover biomarkers in ALS. And, I was involved very early on, at least 25 plus years ago now, looking at studying biomarkers in individual with the disease. And, I went out in that effort mainly because things that we were doing in our model systems weren't translating to humans, and they were failing in trials. So we needed to get more information of what's happening in humans, what's changing in people, how does it change, when does it change? And so getting and collecting biofluids that are linked to detailed clinical information was really critical. And so, as James mentioned, we put together this study with a host of sites, and I think it was about 8 sites overall. And again, those are part of the co-authors on the paper. And the goal was, okay, we had a number of labs have discovered some biomarkers, but the traditional way was sort of what was called cross-sectional. You got one time point, one sample from somebody, and you relate it to the clinical data that you had and really comparing maybe ALS and healthy controls or ALS and maybe another disease. We didn't know too much about how these changes or how any of these biomarkers might change over time in individuals. And really what was lacking back then when we started this study was a really deep number of samples or longitudinal samples from ALS patients that then was linked to detailed clinical information that we could use in this study. And as James mentioned, the samples have been used in studies around the world for a number of years. And so really that was sort of the impetus of the study, and biomarkers that we looked at and selected for this study were those that were sort of topical at the time or coming up, and we were really interested to see how they changed in a longitudinal manner.
That's fantastic. It's so important. And you're right, there's so many biomarkers that I think people are hearing more and more about biomarkers in ALS and forget that, like you said, simple things like getting your blood pressure taken, when you go for your physical is a biomarker, and biomarkers are, certainly nothing new, but in the world of ALS, finding new biomarkers, I think is the thing that's really starting to evolve and be exciting. So that's tremendous. James, I don't know if you have anything to add before we start going into our questions.
Well, I guess I could just give maybe a brief overview of what we presented in the paper, so people maybe have an
That'd be
idea.
wonderful.
So again, Bob and I both talked about the fact that we were part of a group that ran this study in over 100 people who were giving spinal fluid and blood and clinical information about every 4 months. And those samples were frozen and went into the NEALS biorepository. And this in this study, in this what's presented in this paper, our goal is really to investigate biomarkers of inflammation in ALS, as well as look at two biomarkers of neurodegeneration, that is neurofilament light and neurofilament heavy. And we used these samples from 108 people living with ALS. I think 85 of those had at least 2 visits. And then we had about 75 control participants that we compared to. And we also looked at key subgroups within people with ALS. So there were 10 who had a mutation in C9orf72. And then we also divided people into those who had fast and slow progression. And then we did our biomarker analyses, and we compared sort of between healthy and people with ALS, as well as the subgroups within ALS. I think it's important to note that I think now people talk about neurofilament, and there's a lot we know about it. Bob was really a leader in this, long before this paper. He was leading and sort of developing the assays for neurofilament. And there were really 2 segments of neurofilament, or 2 different flavors of neurofilament that we were measuring: neurofilament light and neurofilament heavy. And those had been explored over years, and depending on the assay, one looked a little better than the other. Our question was, at the time, based on our current assays, which one performed better? And for neurofilament light, we were using what at the time was a relatively new assay called SIMOA, or single molecule array. And what we found was that many of the inflammatory markers that we looked at, and we looked at really dozens of these, were pretty variable. They went up and down. They didn't really divide people into, having ALS or not having ALS. They weren't different between the fast and slow progressors. But we found 2 that looked promising, and that's okay. That's actually a promising result, to come out with 2 that look good. One is called MCP1, and it's higher in people with ALS. It was somewhat distinguished people a little bit better in CSF than in blood. And another one was IL-18, which is another inflammatory marker. And then we looked at neurofilament, and it was somewhat earlier days, but just to be able to do this on a large data set with longitudinal samples was really, really powerful. We found that in people living with ALS, neurofilament light and heavy were both higher compared to controls. We saw that in fast progressors, they were both neurofilament light and heavy were higher in fast compared to slow. Somewhat unexpectedly, we found that neurofilament was higher in people with C9 mutations, and I think we may have to come back to that one. I'm not sure that one bore out over time, but that was true in this data set. They were stable over time. That was another big question. Did they change over time? They were actually, both of them were pretty stable over time, but small changes in them. They're higher in spinal fluid than blood, but I think what was really important in this study is we could look at correlations, and that they really correlated spinal fluid and blood. And with the assays we were using, we could detect the elevations both in blood and spinal fluid. And that really opened the door for future studies to really focus on blood, which is much easier, obviously, for us to get and for people to give than spinal fluid. I think in the assays, and Bob, I might let you talk about it a little bit, but in this assay, I think neurofilament light maybe edged out neurofilament heavy. And we actually suggested then at the end that, maybe neurofilament could be used to enrich for more homogeneous patient groups in clinical trials. So that's sort of an overview of the paper.
Yeah, it's a great overview, James. Not too much more to add to that. And I think, as you stressed, I think the other interesting thing was not, both the longitudinal nature of change, because clearly if you want to use a biomarker in a clinical trial format, you need to know how it changes over time in people. If you don't know that, you have no idea what an impact of a drug may or may not do. Is it going to force it to go up or down? Maybe it goes up or down naturally in the patient population. And so those are important questions to answer. And then also having sort of matching CSF and blood from the same individual that we were doing our assays on, we could correlate the levels of those individual proteins in the CSF and blood over time in individuals, and ask really important questions on how does that correlate. And as James mentioned, that has led to a lot of studies looking more specifically at blood if we know it correlates well between the CNS and the periphery.
These are fantastic. I think they're going to tie in really nicely with the questions. I know we have so many, and we have about a half an hour, so we should be able to get through all of them. But we have really excited to introduce Lori Larson Heller. She will be our first panelist to ask our questions. But first, Lori, it would be great to give your background and your connection to ALS as well. So, Lori.
Hi, everyone. I'm Lori Larson Heller. And first of all, thank you for allowing me to be on this panel. I thought the research paper was extremely well done, and I am enjoying participating in this. So thank you for that. My connection to ALS is, well, it started in September of 2018 when my husband was diagnosed. I left a 35+ year business career that day to be his sole caregiver, and we didn't have a lot of time. He passed a little over 18 months later in early 2020. Pandemic had just started, so it was a great time to lose someone locked in your house. But I did not get involved in any of this advocacy until after he passed, because it went so fast that I was just busy trying to stay ahead of the game. And when he passed, I thought I'd go back into my business career, but there wasn't a bone in my body that wanted to do that. And everyone on this call and in general knows that this disease can affect you in ways you never imagined. So the thing I hated the most has become my purpose. Didn't return to work. I basically volunteer all my time on anything ALS. So I started a small fund that I give money out for research, and I've raised about $1.2 million in the last 3 years with that. I'm on 6 patient advisory committees. I served as a consumer reviewer for the CDMRP program last year for the Department of Defense. And interestingly, that was on biomarkers, grants for biomarkers last year. That was fun. I'm on the scientific review committee for Hop on a Cure. I'm obviously a NEALS research ambassador and a PAC member there too. So I'm just, anything ALS. I live in Minneapolis, by the way. And so somehow through the local neurologist here and other ways, I seem to be the ALS person in Minneapolis. So I get connected to lots of families with a new diagnosis, and I try to help them through that. And what's hard is they become friends, and then I lose them, just like I did my husband. But it's a passion for me. So I'm happy to be here.
Wow, remarkable, Lori. It's inspiring, and my heart goes out to you for your profound loss. But to be able to have the strength to run back into the fire that is ALS, rather than run quickly away.
Yeah.
Really something. So thank you for all you are
You're
doing.
welcome.
Yeah.
I'll jump right into my first question then, and it relates to that. The article, I guess, suggests that the biomarkers you studied could be used to predict ALS progression, right, as well as treatment effects. And my question related to, and I realize this was a longitudinal study, which makes sense, but the question was whether you felt any of this biomarker stuff that you studied could be used also as a diagnostic tool. Because obviously the sooner we can get to a diagnosis, the sooner we can get people into trials and on medications and so forth. So that's the question, I guess. Why or why not could these biomarkers you studied be used for a diagnostic tool?
Yeah, I think, for the biomarkers we looked at in this publication, obviously neurofilament is one that has potential for an aid for diagnosis. And I've actually been pushing that for a number of years, that it could be used for an aid for diagnosis for ALS. The critical thing is how any of these biomarkers change with respect to ALS, but also with respect to other diseases. And so it's the specificity of the change that you see with neurofilament is a large change in ALS, even larger than many other neurodegenerative diseases. So it's helpful in that regard. Inflammatory biomarkers are more challenging because inflammation, you can have an increase in inflammatory biomarkers based on having a cold, for instance. So that can be variable amongst people, and it's hard to use some of these same inflammatory biomarkers for diagnostic purposes for a complex and rare disease like ALS.
Yeah, I think that's right. I guess this is a great question. And I think, as a field, it was only 10 or 15 years ago that we really, really sort of standardized how we talked about biomarker uses. And so, if we think about a few of those uses, we could think about prognostication, which is a biomarker that tells you how will the disease go from here. Will progression be fast or will it be slow? And in order to sort of meet that need, there need to be probably different levels of that biomarker. So in the case of neurofilament, a higher neurofilament would predict a faster progression in the future. A disease monitoring biomarker is one that probably changes over the course of the disease, something that maybe starts low in the beginning and gets higher as it goes along, or vice versa. And so you can see how it would be hard for a biomarker to maybe take on both of those roles, perhaps not impossible, but a little difficult. Diagnosis, the best diagnostic markers are ones that either aren't present in people who don't have the disease, or can really be distinguished at the earliest stage of the disease. So you wouldn't want, a disease monitoring biomarker maybe starts more toward normal and gets more abnormal over time. That maybe isn't compatible with the best diagnostic markers. Neurofilament is good at prognostication. Again, higher levels correlate with faster progression. It is elevated in people with ALS compared to controls. And so I actually think now that it's commercially available, it is actually a part of the sort of testing that many of us are doing at the time of diagnosis. It's not specific to ALS, so there are other things that can make it go up. And so it would never be the only test that you're going to send, but maybe it's part of the thinking that goes into things. The other thing I would say is it's not entirely sensitive. So there can be people who have ALS and a normal neurofilament level.
Okay, great. That's very helpful. My next question, and Dr. Berry kind of hit on this, I think, in the introduction of the article. So maybe a very short answer to this, but I used to think that the NFL level could only really be measured in the CSF, but obviously your article made it clear that it's the blood or plasma and CSF. And I was curious if, obviously less intrusive is better for the patient, as I'm always advocating for the patient. So that would go back to the blood. Is one or the other more reliable? Or, I mean, I think I heard you saying in your introduction that blood is really doing as good of a job now as CSF. Is that true? At detecting?
Bob, you've done a lot of work developing these assays. Do you want to talk a little bit about this?
Yeah, I mean, I've probably looked at a few thousand. So it does work quite well. The levels are much less in the blood than it is in the CSF. So if you had CSF, the amount of neurofilament you detect is much higher, and it's much easier to identify. As James mentioned, there can be some individuals that have ALS that have very low levels of neurofilament. And so those with lower levels, even in the CSF, then have very low levels in the blood. And so you start to get close to what is the sort of range of normality for levels of neurofilament in the blood. So that can happen on some individuals, but overall, levels in the blood can be reliably measured and are typically elevated over sort of an age-matched control, healthy control for that individual.
Okay, great. Another question was, and maybe I'm making a bad assumption, but assuming that we learn a lot more in a clinical trial using fast progressors, just if we're only dealing with a 6-month period, someone needs to be progressing more quickly. So if that being the case, and hopefully that would lead to more acceptable endpoints, how far away do you think we are from being able to use maybe an NFL level as a sorting mechanism to sort of get fast progressors into trials? So it becomes part of the inclusion-exclusion criteria.
This is a great question, and it's one that we're all sort of thinking about in the field. And there are beginning to be trials actually that are using neurofilament as an inclusion criteria. We've done some work using the data that we have from the Healy platform trial, and the statisticians have had a really gone a long way to kind of look at that data to try to understand, how much different is it to sort people by neurofilament than it is by a prediction model using clinical characteristics, or even maybe just clinical characteristics themselves. How long has somebody had disease, and how has the disease progressed? And there are sort of pluses and minuses to using any of those ways to kind of sort, to try to identify people that would be most suitable for a trial, and try to keep those trials relatively brief and learn what we can. We talk about needing fast progressors. There's a little terminology that I'll just point out, which is what we're trying to do in a clinical trial setting is slow the progression of the disease. I mean, we would love to stop it or even see recovery, but at very minimum, we want to see slowing of disease. In order to slow progression, we need to see progression. And so maybe the first goal is that if people are not going to have progression over 6 months or 9 months that we run a clinical trial, they become not informative to our analysis. And so, it's really a matter of, I think, really trying to, find the people that are informative in the setting of a trial, and include as many people as possible in the process of getting to that group. And so you don't want to exclude people if they are going to have some change and would be able to contribute to the data in the trial. I think it still remains to be seen whether neurofilament does this better or clinical characteristics. There is one just technical issue that sort of is important, which is many of the assays have to be batched together. So we need to run, 40 or 80 people at the same time. And that creates some challenges when we're trying to use this to screen people, because we need results back quickly. But there are some new assays now that are being run in machines sort of one at a time, and that'll be really helpful for this use.
Great. That helps a lot. I didn't know there were studies or trials in some cases that are already using NFL. And I think last question, I had a few more, but we'll move on to Dr. Johnson. But I was curious, I saw that the mean age in your study was 56.9 years of age. And it seems there's so many younger people being diagnosed these days. I was just curious, I guess in particular, the biomarkers you were studying, but really my question relates to any biomarkers. Are they different depending on age of the diagnosed person, age, fitness level? Do those things affect what we see in a biomarker?
Yeah, I think it depends on the biomarker. So, if you're looking at neurofilament, so there's been a number of studies over the past probably 3 to 4 years looking, first off, what's the normal value in the quote unquote healthy population? And you do see an increase over time. So, if you're looking for, quote unquote cutoff levels of neurofilament, that's going to change as you work across age groups. And so as one ages, you just have a little bit slightly more neurofilament in your blood over time. So yes, I mean, age matters with respect to the normal amounts of neurofilament and other biomarkers. So it's a very important question that we always have to keep in the back of our mind when we're looking at biomarkers and trying to dictate whether or not how useful it is. But the age of the individual can impact how we interpret that number for that biomarker.
Okay, but it sounds like it can be correlated. So
yeah.
It's the interpretation really. So, okay.
Yeah.
That's great. I again, really enjoyed the article, and I think I will turn it over to Dr. Johnson.
All right. Hi, Stephen Johnson. I'm a neuromuscular neurologist at Mayo Clinic, and I lead the ALS clinic here. I guess as far as my connection to ALS, I first learned about ALS as a medical student, rotating on neurology. I was fortunate to work with an amazing mentor who taught me about ALS and how much can be done, contrary to sometimes popular, but I think incorrect belief. And then I had a family member come down with ALS, and during my training continued to see patients with ALS. And so overall, these experiences really solidified my commitment to making ALS a focus in my career to try and figure out how do we beat this disease. So I guess I wanted to start with a two-part question for the panel. The first, taking a little bit of a step back and just asking, what is the process for selecting a biomarker to test? And then the second part being, once identified, how do you validate the biomarker? How do we know that they're accurate?
Yeah, so great question, Stephen. So this how to select a biomarker to test like in an upcoming study. So one could do a few different things. You can either discover biomarkers on your own. So that would be a series of experiments where you're going to take a group of samples, run it through a sort of a discovery platform for biomarkers, and identify those that are candidate biomarkers that you want to further study in your second analyses. Or you can look in the literature and identify biomarker candidates of interest to you that you want to further study. And those again might reflect particular questions in mind. In this case, for this paper, it was looking at sort of neurodegenerative and neuroinflammatory based biomarkers. And so those were the ones that we selected for this particular study. And then how to validate and confirm, I guess there's, and even early on, I think we've gotten better as a field, but early on, those are great and challenging questions. And so what's a validated biomarker? And what's the definition of that? So, normally, if I always say it's easy to discover biomarkers, you run some experiments, you run a t-test, you can find things that look different. Those are all candidates. Then you got to verify the results in a separate study or separate cohort of patients. And in a best case scenario, have your results and findings replicated by another lab elsewhere to show that, yeah, you actually have something of interest, a candidate of interest. Then you need to actually work on, as James mentioned, sort of assay development. How good is the assay that you're using to measure that biomarker? What's it really measuring? How reliable is the assay itself? So there's a large list of sort of parameters and validation steps to not only confirm the biomarker of interest, but also the assay of interest to measure that biomarker.
I think that's right. I might just jump in with just a couple of words that people might hear sometimes when they're hearing about biomarker identification, and Bob described these processes, but one is called unbiased approaches. So unbiased approaches are kind of testing all the proteins we can think of, or thousands of proteins, say in blood or spinal fluid, and just trying to see what comes to the surface. And you can imagine that AI is now taking a front seat in this. The other way is targeted, and that was, Bob talked about looking at the literature, looking at other experiments, things that already look promising, that the thread needs to be pulled a little harder. That's kind of targeted. And when it comes to validation, I mean, I think it's a long and complex process, as Bob laid out. But one of the things that I think is really important is that it relies on replication studies. It relies on different people, different labs, different hands using different samples in studies that are not related to one another, sort of getting the same result. So, I mention that only because sometimes I think people hear about similar studies that are going on in different places and think that maybe those are duplicative and not important. And I would just make the case that while that may be the case sometimes, and we don't want duplication, replication is really, really important for the field in this exact way.
Yeah.
Thank you. That's excellent. Another question I had was, in this paper, patients with C9 or F72 mutations had elevated TNF alpha, or tumor necrosis factor alpha, so an inflammatory marker. Does this suggest that ALS can be both inflammatory and genetic? And do the findings of this paper change your view on that at all?
So it's a great question. I think the answer is that it probably can be genetic and have an inflammatory component, and there are lots of ways that we can imagine that happening. One might say there's an inciting event, which is a genetic driven genetically, and that causes a cascade of events that in sort of an unrelated way or downstream way causes inflammation. There could also be a direct relationship, and I think in C9 we actually see a little more inflammation, I think, than we do in other forms of the disease when we look at the tissue, and so there may be a direct relation between what the gene does and inflammation, so that the healthy function of the gene may be to act as a brake on inflammation, or a mutation may cause a gene to take on a new function, which is sort of to step on the accelerator for inflammation. So I think there are a number of ways that they could be related, but I think we're seeing that here.
And then just one other thing to add, really good answer from James. The other thing to add is that neurodegeneration itself triggers inflammation. And so as motor neurons die and other neurons die, that actually can trigger inflammation from the surrounding glia. So it's not surprising then that even under genetic causes of ALS, you also see higher levels of inflammation.
Thanks. That's really helpful. That kind of leads into my next question, which is a little bit of a tough question, probably. So what would you say to someone who argues that biomarker changes we see are markers of the disease process, such as the degeneration of the motor neurons, rather than what's actually driving the disease process? Is there a way we can reliably distinguish between the two?
And that's a really tough question. So great question, really hard to answer. I look at it, I feel that these biomarkers are both drivers of disease. And again, biomarkers, here we're talking about proteins, but, genetic variants that cause disease are biomarkers. They're genetic biomarkers. So what is the driver? What is is it related to the process itself? I think a lot of these probably are, but to me, the most important question really is what's the trigger? And that we really don't understand. And so, an individual harboring a genetic variant that's causative ALS has that their whole life. And so what was the trigger in the individual? And I think after the trigger, all these processes develop. And again, these biomarkers are reflective of underlying events. But to me, I think the most important question is finding that trigger.
Yeah, and again, I'll just maybe add a couple of words that people might hear. So one of the things we talk about is the causative pathway. And that is, some inciting event happens and sets off a cascade of events. And that cascade could be broad, but there is a pathway that, this domino leads to that domino, leads to that one, leads to that one, leads to the next one, leads to weakness in this case, or loss of motor neurons. And a biomarker may be in that causative pathway. And I think one of the things about biomarkers that are in that causative pathway is they tend to be pretty reliable at telling you what's going to happen in the end. So they're good at prognosis, they're good at diagnosis, and you don't have to worry a lot that they're giving you a wrong signal. There can be important biomarkers that are not a part of the causative pathway, that they're sort of a side pathway, and they can still give you an important readout on how things are going. But because they're not in the causative pathway, they don't make good targets for disease. And under certain circumstances, they can actually give you the wrong readout. So, you could, for example, find a drug that treats the side pathway and not the causative pathway. And, the biomarker changes in a way that you would expect, but you don't affect the disease outcome. So we have to be cautious about this, but that's kind of how we conceptualize.
And finally, another last comment is really, we're working more towards finding biomarkers at or before clinical onset of symptoms. And again, there's, a few studies. Michael Benatar initiated some of these studies a number of years ago looking at asymptomatic gene carriers. And, it's a long process, but I think finding biomarkers that occur prior to onset of symptoms, I think will also help identify both pathways and biomarkers that are important for the onset of disease, at least in certain genetic forms of the disease.
Thanks. Yeah, that's really helpful. And I to James, your point, following the breadcrumb trail, and eventually we'll get to the source and then be able to really test it. So, well, thank you both very much, and I'll pass it off to Jean.
Thank you so much, Jen, for having us. Thank you to the two authors for being here, and thank you to the prior panelists for your great questions, some of which wrapped up some of mine. Wonderful. So my name is Jean Swidler. My great-grandfather, grandmother, mother, and aunt died of ALS, and my uncle just got diagnosed with ALS a few months ago, and I know that I carry the C9 expansion that causes the disease in my family, though I'm currently asymptomatic. And I'm part of Genetic ALS and FTD and the Legacy, an organization that seeks to provide education and support resources to and provide advocacy on behalf of the genetic ALS community. So just jumping into some interesting questions coming out of this research is, given that neurofilaments are essential structural components of axons, if one knew they were predisposed to ALS or other neurodegenerative diseases, would it not make sense to attempt to ensure no dramatic rise in neurofilament levels is allowed to happen? Or in another sense, does it make sense to look at a rise in neurofilament levels with suspicion, especially in those who know they are at elevated risk of ALS?
I mean, Jean, really good questions. Let's take this. I think I'd start with the second one. Should we be cautious? So if somebody carries a gene that can cause ALS, should we be cautious if we see a rise in neurofilament and really pay attention to that? I think the answer is absolutely. Neurofilament, everyone has some level of neurofilament in their blood and spinal fluid. It should be below a certain threshold to be considered normal. The reality is, like any test, some people who are healthy, maybe slightly outside of the normal range. But if we see a rise in neurofilament in somebody who carries a gene that can cause ALS, I think we do need to be cautious. Now, I think the process would be to really do an evaluation of, is there anything else that could be injuring neurons that's not ALS that that needs to be treated and could account for that rise. And those could be things like head trauma or other, even to some degree, to a small degree, a pinched nerve in the back can cause a small rise in neurofilament. But there are other diseases like Guillain-Barré syndrome, other neurologic diseases that can cause some rise in neurofilament too. So you want to be thoughtful about those. And I think it deserves a workup. I mean, I think it deserves a careful evaluation because it could signal the onset of the disease. Your next question is, or the first part of the question actually is maybe even more complex, which is, does preventing a rise in neurofilament stave off the onset or prevent the onset of ALS in somebody who carries a gene that could cause ALS? I have to say, I mean, I find this to be a fascinating question, and I really don't know the answer. There is, of course, a question about whether head trauma is related to the subsequent onset of ALS amongst people who do or don't carry a gene. And that obviously is something that could cause a rise in neurofilament. So I have to admit to not knowing the answer to the first part of your question, is preventing a rise in neurofilament from other reasons, from other injuries, a way to help prevent ALS in people who are at high risk. It makes a certain amount of sense, but I just don't know.
Yeah, no, great answers, James. I don't think we know the answer to that first one. And to James's point, neurofilament can rise for a multitude of reasons in addition to ALS. And if we attempt to ensure no dramatic rise in neurofilament, would that sort of stave off ALS in asymptomatic gene carriers? I don't think we have an answer to that yet. I mean, it's a great question, and it's one that we'll be exploring in different studies, and we'll know the answer over time. At the moment, we don't. But neurofilament is, it's a really important biomarker for ALS, but it's just one biomarker as well. So if you stave off a rise in any one biomarker, will that show or demonstrate a lack of disease progression? And we don't know the answer to that either. So you might imagine that, even if neurofilament levels don't rise appreciably, they may rise slowly, and there are other pathways involved that are damaging and causative of the disease process, and therefore symptoms that will appear and the disease will slowly progress, even though neurofilament changes really aren't rising in a dramatic way. So I think there's a lot to learn, but it's a great question.
Wonderful. And I'll just make this my last question. If a biomarker is prognostic and somehow it is proven that an intervention changes that biomarker to a level that means the participant has a better prognosis, would that not mean the marker proves the intervention works to improve prognosis?
Another really great question. I think this is one that we're thinking about a lot because we're now at a stage where for people with a mutation in SOD1 that's causing ALS, we can treat them with tofersen, and tofersen reduces it slows the progression of the disease and it reduces neurofilament. So I think the question that is often on our minds when we're in clinic, either as a patient or as somebody who's treating patients. Okay, let's say somebody with SOD1 ALS comes in with a neurofilament of 300, which is quite elevated. It depends on the assay. One of the things we haven't talked about is different labs actually have different standard numbers, and so it's very hard to compare across, but we're making progress, and so but the state of it is now, it depends on what lab you get tested at. But let's say someone comes in with a number like 300, which is high. And we treat them with tofersen and their neurofilament reduces to 50. Does that mean that they have the prognosis of somebody who has a neurofilament of 50 from that point forward? I hope so. I mean, I think that's what we're thinking. Now, it's not granular enough. I want to be very careful to say not everybody who has a neurofilament of 50 has the same progression rate, and it's not quite like a thermometer. I think it's better to think, a lower neurofilament, a higher neurofilament, a middle neurofilament. That's probably the best that we can do. And even then we can be a little surprised. But your point is right. No, I mean, I think yes, if we can reduce the neurofilament, we can feel like we are destined to slow the progression of the disease to someone who has that kind of new level of neurofilament. I'll just extend that a little bit to say, if somebody is already in the normal range, is there sense in pushing the neurofilament lower? And I only extend that question to say, I have no idea. I think we don't know if that's true.
Just to add on to James's good answer, we're still learning more about if you're talking about neurofilament here as your prognostic biomarker, what reduction in neurofilament is sufficient to sort of convince ourselves that the treatment is beneficial. So is it a 20% decrease? So moving to 300 down to 240? If it goes all the way to 50, I completely agree. I think we have a demonstration that you're really impacting the disease process and probably improving prognosis. But if it's a much lower level of reduction, how do you interpret that result? And that we don't know yet, and we're learning more. I'd also like to say, there are other biomarkers that are thought about around the area of prognosis. So, it could be moving forward. We not only look at neurofilament, we look at a few of these others and say collectively as a group now, are all of these markers that somehow relate to prognosis changing in what would be in a beneficial manner? And then we might have, an increased confidence in how we interpret the result.
Amazing. Well, thank you so much. And Jen, I'll kick it to you. You're muted.
Thank you so much, Jean. Your continued strength just amazes me and inspires me every day. I think I tell you that all the time, but it does, and you're just so well versed on all of this as well. All of you panelists are just phenomenal. It's such an incredible lineup today. I am very cognizant of the time. I have one more question that I just wanted to ask, and I often people will ask me this, and I don't know the answer. And as we talked a lot about neurofilament, but and just pivoting a little bit back towards inflammation, I know that there's so many things that cause inflammation, right? Everything causes inflammation. You could bang your hand, against a wall as you walk by, or and that's going to cause inflammation. A lot of people, eat a very anti-inflammatory diet and things like that. And do those things, those everyday sort of things, or I guess more importantly, does diet play into the types of inflammation that you're talking about with neuroinflammation, or is that completely separate? I've heard that question asked, and I don't know the answer to that.
Wow, that's a great question. Thinking about how diet can play a role in a neuroinflammation, usually if I think about that type of question, I'll start thinking about gut microbiome. And so how the diet is impacting on your gut microbiome, because we do know that can impact neuroinflammation. And so within the gut and your microbiome there are a number of metabolites, short chain fatty acids, et cetera, that can be generated. And those can both impact the barriers within the CNS, and also impact peripheral cells that can infiltrate the CNS and therefore impact neuroinflammation within the CNS. So there's a connection there. In ALS, I think the gut microbiome studies, there's still questions around that. I think it's been better studied in a few other neurodegenerative diseases. But the basis is there, and clearly, the nervous system is connected to the gut. And so there's direct connection there. So there's definite ways in which, the diet and the gut microbiome can impact inflammation within the central nervous system.
Terrific. That's great. Thank you so much. Well, I think we have come to the end here, and this has really been fantastic. Dr. Berry, Dr. Bowser, I can't thank you both enough. This has really been so enlightening, and once again proving to be a fantastic way to engage the ALS community in all these important pieces of work, but specifically as we talking today about your publication on biomarkers. So we can't thank you enough for lending your time, your expertise, and of course your immeasurable kindness. To our panelists who represent the ALS community today, who have shared your personal stories, I thank you so much as well. You've all been impacted in various ways by ALS, and my heart goes out to all of you, but I'm in awe of your strength, as I said, to run back into the fire to help all others. So Dr. Berry and Dr. Bowser, I will ask you the same question in closing that I have been asking at the end of each of our webinars, and that is very simply, what is the most important thing that you hope the ALS community will take away from regarding reading your publication and then from the information today?
Thank you. First of all, thank you so much for being here, and thanks to everybody who's been here. I want to say, when the NICE committee, sort of proposed doing these, I knew it would be a good idea. I didn't realize it'd be so much fun. This is great to sit down with this group of people, and even Bob. Bob and I, just kidding. Bob and I are on lots of phone calls about upcoming projects and ongoing projects, but it's fun to get some time to just sort of sit down and reflect on the work that we've been a part of. One of the things I want people to take away from today, just in addition to all of the kind of science that we talked about, is that none of this science could be done without people really contributing to the studies. I guess never waste a good opportunity for an advertisement. Bob and I are working on a new project called All ALS, which has big goals of enrolling really thousands of people with ALS. We have 35 centers across the country that are going to be a part of this, and we'll be collecting clinical information and blood, and in some cases spinal fluid. And it's really driven by the successes like the ones in the paper that we're describing here, where we're finding biomarkers that really are changing the way that we can do clinical trials and understand the disease. And so I think, if there is a way for people in the community to get involved, whether it's through All ALS or other studies, that would be amazing, and has a huge impact.
And Jen, I also just want to sort of reemphasize, our gratitude for inviting us to be here today. It's been, as James said, a lot of fun, even though James is on the phone as well. But it's been a tremendous joy, greatly, exciting, but almost reiterating again what James said. I think the biggest take home is just that, none of this work gets done without participation of, the patients and friends and family of the patients, and the importance of that. It's really having the, enriched clinical data, longitudinal samples that not only enables our studies and ones that we can envision, but our ability then to share all this data and all the samples to the research community around the world. And that's where we not only allow our work to get done, but, amplify the effect of, the participation of the patients to allow research around the world to get done. And that's how we're going to make an impact on this disease. So I think that's as James said, the big take home from this paper.
Yeah, I see so much unity in so many aspects of, this type of thing, and populating trials, populating information for, research publications, whatever it may be. It truly does take everyone to get things done, and when that clicks along so nicely, it really moves the needle forward. So thank you all so very much. This has been so wonderful. It's been such an honor for me. So thank you all, and I will look forward to the next publication under biomarkers as well in a couple weeks.
Bye.
All right,
Thank
take care.
you.
Bye, everyone. Thank you.